afternoon. Thank you all so much for coming. My name is Chad Griffin, and I am the president of the Human Rights Campaign, and it's a real pleasure to welcome you to HRC for what is a critically important discussion about how HIV and AIDS, and particularly the stigma surrounding it, affects vulnerable populations, including the LGBT community. The fact that we are even able to be here for this discussion is worth noting. After years of work by so many advocates, we were finally able to leave the US government's draconian HIV travel ban in the dustbin of history. HRC is proud to have been a part of that coalition, working with Congress and the administration to make our borders open to HIV-positive visitors and immigrants. As the HIV/AIDS pandemic continues to ravage our communities, there needs to be continued emphasis on issues and concerns relating to men who have sex with men and transgender individuals, which we'll explore in depth in our panel discussion this evening. At a time when gay and bisexual men account for 3 out of 5 new HIV infections in this country, there is no time for us to waste. The disease is also taking its toll on our young people, especially in communities of color. New infections are twice as high among young gay and lesbian men of color compared to their white peers. We must make sure that resources are available for prevention as well as care and treatment. And we must do, the work of educating the public about what HIV is and what it isn't in order to tear down the stigma that serves as a barrier to people living their healthiest lives. Planning this event has been a real and great collaboration, and I want to thank our co-host this evening, the International Association of Physicians in AIDS Care, the International Treatment Preparedness Coalition, and the Pan American Health Organization. Thank you to all of those who prepared this evening and put this panel together. With that, it's now my pleasure to welcome Robert Clay, Deputy Assistant Administrator in the Bureau for Global Health at USAID.
Thanks very much, and it's a real honor to be here, to be with all of you as well, particularly because of the topic that we're talking about, stigma and discrimination. I've been working in the field of HIV/AIDS for a little over 20 years, and my experience, and I'm sure many of you in the room, is really demonstrates and shows that stigma is one of our real challenges as we move forward. It's continuing with us. It's not something that we've achieved or we've accomplished. It's something that continues to raise its head over and over again. And I'd just like to share a couple of experiences that I've had in my own personal career to illustrate that. First, when I was in Zambia, this was in 1998, at the heart of the epidemic. Zambia had HIV/AIDS prevalence for about 20% for over 15 years, so the mortality was tremendous. And even some of the countries in Southern Africa that have much higher rates now, they were single digits at that time. But Zambia was really a very highly affected country. And after I arrived, about 3 or 4 months into my stay, I realized that my secretary was showing some signs of illness. And over the course of about 2 years, maybe a year and a half, we watched as she got weaker and weaker. And of course, at that time, there was very little discussion about what kind of illness that she had. Well, she eventually passed on. Unfortunately, we tried as much as we could, but we didn't have the ARVs that were available to her to help her along. But what was really a memory was when I went to the funeral, and as the director, I was asked to speak. And I thought, what an appropriate opportunity to talk about HIV/AIDS and the consequences of AIDS. And of course, the family came up and they said, please don't mention that she died of AIDS, because of the effect that it would have on her family, on her child, on the whole situation, particularly with property that was in dispute with the family. So it was very much of a silent disease, and when HIV/AIDS first came along, it was really known as sort of the death sentence. With ARVs available, we all felt that that would make this a very different type of disease in terms of the stigma and discrimination. Now people could get tested, they could actually take the drugs, and they wouldn't have this death sentence around their head. But unfortunately in Zambia, recent surveys that have been conducted shows that despite widespread use of ARVs, discrimination and stigma within the population is still very, very large. So it's still with us, despite the fact that it's not necessarily now a death sentence for you. The second example was when I came back in Washington. I spent a lot of time with some of our colleagues here on the Caribbean program. And we were looking at our activities, developing strategies, and it was very striking to me in the Caribbean how stigma was such a rampant issue. And it was something I had not expected. Coming from Africa, you expect that within that environment, but within a more progressive, a more developed area, I was quite surprised. Again, stigma is still there. And of course, one of the main areas that, or one part of the health system that supports or is our source of stigma is also the health workers and the way their attitudes towards individuals. And I'm sure on the panel tonight we'll hear a little more about that. So I think what we've been learning over and over again is that humans discriminate, the virus does not. And so we have to make sure that we have programs and have strong actions to be able to change the attitude and to try to reduce stigma, because stigma drives this epidemic under the ground. It makes it worse. It makes it very difficult to reach people and to provide the care that they need. The U.S. is trying as best as we can on our side to help, looking at a variety of different areas, trying through our ambassadors and our leaders to have them coming out, being quite vocal about the importance of HIV/AIDS and associating themselves with some of the high-risk groups that maybe in country people are a little awkward and maybe the president or the leaders will not want to do. And so it sets a good example. And there's a lot of press that comes along with that. And I've seen in some of the countries I've served that's a very important addition. We also are working with institutions of people living with AIDS to build those institutions so that they can provide the kinds of support and long-term continuity in their country on issues such as stigma. Of course, education is key, and a lot of our programs focus on educating broad audiences on the issues of stigma and discrimination and on facts about HIV/AIDS, as well as looking at some of the legal issues that surround the issues of HIV/AIDS in countries. So we have lots of work to do. This is, I think we all had thought that this would be an issue that would be solved a lot earlier, but it's still very, very much a live issue, and I look forward to the panel tonight to hear ways that people have both have addressed this within their own personal lives, but also in programs and in activities that they've been involved in. But again, thank you for inviting me to speak.
Good evening. My name is Jose Zuniga. I'm president of the International Association of Physicians in AIDS Care. It's my deep pleasure to welcome you to this affiliated event, AIDS 2012. I was struck as I was listening to the comments, looking behind the speakers at these panels from the memorial quilt, and thinking that for every one of these panels that are in exhibit here and elsewhere around the city, there are millions more, countless more people who have been affected by the HIV pandemic. And it just should remind us constantly of the work that is so important for us to advance. I'm very proud to be hosting this event with HRC, the Pan American Health Organization, and the International Treatment Preparedness Coalition. Thankful to the faculty who are joining us. They all bring unique expertise to the table. and thankful to all of you for joining us. There are many other events going on this evening, competing for our attention, so I'm very glad you're here. I'd like to recognize a couple of people before we move on to the program. The chairman of the IAPAC Board of Trustees is here with us, Rabbi Alan Freeling, as well as two of my vice presidents, one I'll introduce at the end of my comments. Ben Young, our Vice President and Chief Medical Officer, will be here throughout the event, and Joan Holloway, our Vice President for Global Health Initiatives, who will be moderating this evening as I have to attend another event, so I apologize for that. But the bottom line message, obviously, of all of the work we're doing here and throughout the conference is that complacency kills, as does stigma, and it needs to be addressed in every form and among every community. The speakers you'll be listening to today have been doing tremendous work in their respective fields, and I think you'll benefit greatly from what they have to share with you. Enjoy the satellite event. Apologies that I have to excuse myself, but with that I'll give the program over to Joan Holloway.
Thank you, Jose. I want to thank all of you for joining us this evening. And Robert, I want to thank you. I know Robert and I go back to PEPFAR early days, and I knew Robert's name for a long time, and I finally met him when he came here to Washington, and he's done some wonderful work with the PEPFAR program, which I think you all know is really the life-saving program for people living with HIV/AIDS outside of the United States. I am thrilled to be here with so many of you too, and I would like to, I think the way I'd like to do this, because we have so many speakers, is I'll introduce our first four speakers, and I'm going to ask you if you could hold your questions, and then when the four of them speak, we can have questions for the first four, then we'll introduce the next four. I just want to make sure that we have enough time for everyone to get an opportunity to speak. And I do want to introduce my colleague over here, Vincent Kanju. Vincent has volunteered to be the timekeeper for us. And because we have so many speakers, I would like to, we want to make sure that everybody keeps to their time. So Vincent is going to be helping with that. So let me now introduce our first four speakers. And the first speaker coming up will be Dr. Raphael Mazzine, someone who I've also known for quite a while. Back to when I was working in the domestic AIDS program at HRSA, the Health Resources and Services Administration with the Ryan White program. Dr. Mazzine is a senior advisor on HIV and STD and hepatitis in the family and community health area of the Pan American Health Organization. And I think you all know PAHO is one of the regional offices of WHO. He's currently in charge of PAHO's strategy directed to focus prevention and care efforts on population and groups at the epicenter of the epidemic in the Caribbean and Latin American region. He is a member of various boards of journals. He's well published. He is a physician who received his medical diploma from the National University of Mexico and his MPH from George Washington University. Raphael, why don't you come and take your seat?
Thank you.
Our second speaker is Dr. Anita Radix. Anita is someone I just recently met, although I heard her for a long time in her work at Callan Lord. She's the Director of Research and Education and an HIV specialist at the Callan Lord Community Health Center in New York. It's primarily a lesbian, gay, bisexual, and transgender serving health center, and it serves a number of people living with HIV in New York City. She holds a faculty position at Columbia University and Yale, and she has been a consultant for the Pan American Health Organization on HIV issues and health disparities. Anita Radix is, besides being a physician, she's now working on her PhD in epidemiology in Columbia University, where she's looking at disparities in transgender communities. So Anita. Our third speaker is Joanne Keeley. And Joanne, I also met as when we started working on the transgender blueprint. She's born in Mexico City and arrived in the U.S. when she was very young. And Joanne is she's social work, social welfare, it says. Has her degree and her master's in social welfare from the University of California at Berkeley. She founded and is director of the Center of Excellence for Transgender Health and PAETC.
It's the Games Education Training Center, HRSA.
Okay, Minority Program Manager. I forgot all my HRSA acronyms, I'm sorry.
Part of the Ryan White program.
Joanne has done a great deal of volunteer work also, and she's co-chair of the board of the National Coalition for LGBT Health and also co-chair of the Transgender Reference Group of the Global Forum for MSM. In 2011, she was honored with the Kaiser Permanente National HIV/AIDS Diversity Award. Congratulations. And then I think our fourth speaker, Joanne. Our fourth speaker is Carlos Andre Oliveras. And Carlos, I just met 20 minutes ago. So he's the regional coordinator of the Caribbean Treatment Action Group of the Caribbean Network of the International Treatment and Preparedness Coalition, one of our co-sponsoring organizations. He's an advisory board member of the Minority AIDS Research Initiative for addressing stigma among HIV-positive men in Puerto Rico, and a member of the Global Youth Coalition on HIV/AIDS. Since 2008, Carlos has been active in the HIV community, working both in prevention and community access to treatment through the Caribbean. Carlos? Our program, with Raphael doing an overview of the epidemiology of traditional and non-traditional challenges in the Americas. And then Anita will talk about determinants of health across HIV-vulnerable communities. Joanne is going to talk specifically about the transgender health blueprint that IPAC and PAHO and a number of other organizations have been working on. And finally, for this session, Carlos is going to be talking about treatment access and empowering individuals across HIV-vulnerable communities. When the four of them finish, then we will have questions and answers. So if you can jot down your questions, I want to make sure everybody gets a chance. Well, thank you very much. And Raphael, I'm going to turn it over to you.
That's useful. Good evening. I'm delighted to be here with you. I want to express my gratitude to the Human Rights Campaign, to the Coalition of Treatment, and to USAID for being here, as well to the International Association of Physicians on AIDS Care. We have thought about the organization of this affiliated event, and I think that we want to share with you some of our lessons learned, experiences, and concerns, and potential responses to challenges we face. I'm going to talk this evening about the epidemiology of traditional and non-traditional public health challenges in the Americas. So this means that I will make reference to some of the conventional issues that we talk about when we discuss the populations and groups which are at the epicenter of the HIV epidemic. But I'm going to make reference to other problems that have not been so well characterized, but they are, in our opinion, public health problems as well, and deserve a better analysis, understanding, and discussion. I think this is the way it works. Well, as I in the meanwhile, as I was mentioning before, I work for the Pan American Health Organization, which is the oldest public health agency in the world. We have been 110 years around, and we are also the regional office of the World Health Organization. Most of our activities are, or all of our activities are conducted in the Western Hemisphere, with particular emphasis in Latin America and Caribbean. So I'm going to make a lot of reference to data and information about this sub-region of the Western Hemisphere. First of all, I want to emphasize that these populations hold conventionally as MARPs, most at-risk populations, but we prefer to talk about populations at the epicenter of the HIV epidemic, require a lot of efforts for prevention and care. Men who have sex with men, sex workers, trans persons, and users of drugs are key populations. And I want to underscore the fact that we are not conflating the trans population with the MSM, as it was the practice for a long, long time. We want to clearly separate the trans population because it has its own characteristics, needs, demands, and problems. So for this reason, I always make explicit reference to trans population, both trans men and trans women. As you know, they have many reasons why they are at more risk. And we know that these groups have HIV prevalence, which is many-fold higher than what we find in the so-called general population. For example, in the region of Latin America, the overall prevalence is about 0.5% among sexually active adults. But among MSM, can be as high as 25%, and among trans women, it can be as high as 40 times, 40% in some groups. In fact, it's 80 times higher when we think that the actual prevalence is 0.5%. So this is a worrisome trend, and we know that some social factors increase the vulnerability of these groups. When we look at epidemiological data, we can see that some sero surveys conducted in different places in Latin America, in this case in 4 countries, in fact 3 countries, El Salvador, Nicaragua, and Peru, we see that among trans women, the prevalence is as high as 25.8%, whereas among MSM is 11.7%. Yet, much higher than the national estimate of adult prevalence, which is about 0.4% in that country. Or in Nicaragua, where we find a disproportionate impact among the trans population and also among MSM who identify themselves as gay. Same situation in Lima, in this study conducted by Hannah Villazan. You see about 33% of trans women were infected with HIV in the surveys conducted, and 18% of MSM identified themselves as homosexual. And in Chinandega, Nicaragua, we also found a disproportionate impact of the epidemic among trans women. When we look at the prevalence of HIV among injecting drug users and non-injecting drug users, the figures reported are as high as 40 to 60% in places where these practices are common. And 25% of all the people living with HIV in Latin America and the Caribbean are men who have sex with men. So we still deal with a concentrated epidemic among some specific groups. The prevalence of HIV among female sex workers is higher than among the general population, can be as large as 10 to 10-fold higher than what we find among adult population. We don't have data among trans persons, but considering what we have identified in those surveys, it could be as high as 40%. among this collective. We don't have any information on risks among lesbian women and among trans men. So we need additional information about the needs and demands of these groups. Less than 35% of MSM know their HIV status, and according to a survey conducted in the region, more than 30% of MSM reported having unprotected anal sex in their last intercourse experience. And we know that some MSM and trans persons use drugs and or have transactional sex. So this adds to the factors that contribute to their increased risk. The HIV prevalence in trans women, as I said, is poorly estimated, but we have some data that shows that we deal with shocking figures. In Rio de Janeiro, for instance, according to one study that we found in 2007, 63% were infected. So again, a worrisome trend. When we talk about the problems of these collectives, we are talking more of syndemics, not epidemics, because a constellation of problems impact them. For example, the same populations that are at increased risk for HIV are also at risk for viral hepatitis. For example, in some studies in the region, we know that about 50% of trans women who make sex work are infected with the hepatitis B virus. And HIV and hepatitis co-infection may be common and is detected among HIV positive people in about 70 to 90% of them. And syphilis is also high among MSM and very high among trans women. Same situation with human papillomavirus and with herpes virus, not to mention tuberculosis. We have seen some figures here about syphilis prevalence. Again, the trans population disproportionately affected. We know very little about the impact on individual and public health of the use of soft tissue fillers that cause ulcers, scars, cellulitis, abscesses, infections, migration of filling substances, pulmonary embolism, kidney failure, because this information is concealed. But we need to face this situation and start providing sound responses. The mental health issues related to stigma, discrimination, ostracism, and minority stress are very documented, and we need additional information on that. And something that is really worrying us a lot is the emotional, sexual, and physical violence in the region. We have some documented experiences of trans women who were denied health services in Chile, for example, discrimination by healthcare providers, policy violence, including verbal abuse, and history of detention. Again, these are public health problems poorly documented. And a lot of bullying and harassment in schools, in health services, and in different public spaces. School desertion and homelessness, particularly among trans persons, trans men and trans women. Alcohol and substance abuse as a coping strategy, and hate crimes. We found that, according to some information provided by the Inter-American Commission on Human Rights, I was translating from Spanish, that over 750 trans women were assassinated in between 2008 and 2011. But this is what we know. This is the tip of the iceberg. In the last 3 weeks, we have been receiving bulletins of at least 2 homicides per week in Brazil, Colombia, Mexico, Honduras, Guatemala, Jamaica, Venezuela, and Argentina, just to mention a few countries where these facts are reported. But can you imagine 2 homicides per week in each one of these countries? So we know that the health sector has some features that affect the access, coverage, and utilization of services by these populations, and we need to deal with those issues as well. And I'm being prompted that I need to wrap up, so I'm going to do that. We are adopting some stances as an organization to deal with this limitation in access to and utilization of services by key populations, and those are, in first instance, pointing at the dimensions and severity of the epidemic in these populations, or rather the syndemic that they face, and support that with some epidemiological data. That has to be, as a public health agency, our first argument to mobilize political will and political commitment. We have to promote the development of sound policies on prevention and care for these populations. We have to develop, and we are doing that already, packages of services and interventions. So far we have completed in collaboration, very close collaboration with different groups, among which I can mention the AIDS Star Project of USAID, the World Association for Sexual Health, IAPAC, and other partners. These packages of services, which are intended to guide the healthcare provider on the necessary steps to tend to the needs of these populations. But above all, we need to count on the community, on their engagement and collaboration. In fact, the second package of services, the blueprint for transgender population, has not been completed yet. Why? Because we want the view and the opinions and the contribution of the community of interest. We want to have their opinions, we want to hear their views, and we want to complete a product based on their needs. So I'm gonna close making some acknowledgements to people who have contributed to develop this presentation. But I have to insist that we have some problems and situations which are visible. They are at the tip of the iceberg. They are rather easy to identify, but under the surface we have many issues that need to be addressed. And I insist on stigma, discrimination, homophobia, transphobia, and violence. We, in fact, in our packages have placed violence as the first public health problem that needs to be addressed, even before in our sequence of events than HIV or STIs for these populations of interest. So I appreciate your interest, and I'm at your disposal to respond to any questions. Thank you.
Would you rather sit there, Anita, or do you want to? I will hand the mic.
Good evening, and thank you all for being here. Always technology. Thank you, Rafael, for a very comprehensive overview. And Rafael highlighted the extremely high prevalence of HIV and MSM and other HIV vulnerable groups. But I think one of the key things we have to remember is, there's a cause for this, and we have to, when we see these numbers, think about what the underlying reasons are for, as you said, sometimes an 80-fold increase in HIV prevalence. So I'm going to really be talking about social determinants of health, just a few slides. Again, to talk about the environments in which people live and how that is reflected in these very high HIV prevalence rates. So we'll be talking about very complex and integrated factors such as the social factors, policies, and health services, also health behaviors and biology and genetics that contribute. And I'm going to be really talking from a perspective as a clinician, not a sociologist or a researcher, but as a clinician who's worked for many years in the Caribbean. And I think I should also start by saying that, although I work there, the research in the Caribbean is quite limited. And when we look at general health information on gender and sexual minorities, the research just really isn't there. Even on issues such as HIV and MSM, it isn't there because of the real problems of stigma and discrimination, and the fact that folks really don't want to disclose their sexuality or even their gender identity. I've had interviewed people in different islands, and 2/3 haven't disclosed their sexual orientation to the medical providers. So most of what I'm going to talk about is qualitative research with very small sample sizes and all the problems that results in. So first starting to talk about the social factors that exist. We know that in many of the, especially English-speaking countries, but you can see here Jamaica, Antigua, Peru, Costa Rica, Brazil, and Belize, gender nonconformity and homosexuality is extremely stigmatized. And we know that the Caribbean culture tends to reject homosexuality, and it's usually very extreme and very violent means. So we've had in Jamaica, gay men and lesbians have told us about verbal abuse from work colleagues, beatings by police, relatives, community members, parents who would rather, have made statements like, if I had known my son was gay, I would have drowned him at birth. We've had issues of hate murder, especially in Jamaica, but other places as well that have been documented by Human Rights Watch. And you can see also, it's related things, increased rates of school absenteeism, employment and housing discrimination, which really hasn't been addressed in many of the islands. This is actually a picture from about, some of you may have known this, about 3 years ago on Valentine's Day, where 3 people were attacked in Kingston, Jamaica, one of whom was a trans woman and 2 gay men. Were stoned by a crowd of about 200 women and children. And, I could show you many pictures like this, and this is just one of many. As far as policies go, we know that legislation and public policies do differ across, all of the Caribbean and also Latin America. You can see here some examples where same-sex marriage is legal in Argentina, Brazil, Mexico City, for example. Where there's access to gender-confirming surgeries and hormones in places like Argentina, Brazil, and Cuba. But on the other hand, you have islands where sex is criminalized, where there's no access to cross-gender hormone therapy or gender-confirming surgeries or therapy, which includes actually all the English-speaking Caribbean except for the Bahamas. In some islands also, what's termed cross-dressing is actually also criminalized. For example, Guyana and Grenada, where there are several court cases going on right now with transgender women who were arrested and fined. We don't know very much about the impact of this legislation on HIV prevalence, but I think this just short slide really highlights. What was done was the prevalence in countries, in Caribbean countries where homosexuality was legal was compared to the countries where still there's very repressive legislation. And, this, you can't prove anything here, but there's certainly a trend that where you have repressive legislation, restrictive legislation, the rates of HIV tend to be higher. So it seems to be really driving the epidemic and increasing the vulnerability of people who are MSM. This is a picture of the 3 women from Guyana who are actually challenging the legislation on cross-dressing. The other issue, of course, is health services, where there are so many barriers. There are very few people who are doing work with MSM. I actually spoke to someone from Caribbean Vulnerable Communities Coalition tonight who told me that their providers in Jamaica are afraid to work with people who are MSM and also people who identify as trans because they believe that the law will criminalize providers who provide care. And I said, that really can't be so. And he said, no, there are providers who think that if they take care of a gay man, that somehow they're going to be prosecuted. So I'm just putting that out there as well. But we know that religion and politics really does set the sexual health agenda in the Caribbean. And there is an overwhelming emphasis on reproductive health, but at the expense of positive sexuality and discussions about health in general, like sexual health and STIs. The prevention is really not targeted to the most at-risk populations. There's a huge lack of confidentiality. And someone who's grown up on a small island, I mean, we'd always joke about it in a way, but it was really serious. The fact that you cannot have a diagnosis of HIV, for example, without everyone knowing about it. Non-disclosure of gender identity and sexual orientation, sex worker status, drug use is really common. And part of it is because of fear of discrimination or actual history of discrimination from medical providers. And of course, this is going to result in delays of care, delays in getting HIV testing or STI screening. And altogether, I think in the interviews that we've done with clients, there is overwhelmingly a lack of culturally competent health services. The last really on health behaviors, I mean, there haven't been too many studies done here, but we know from some of the literature, some of the reports on trans women, and most of whom are trans women sex workers, that there are high rates of substance use, especially cocaine in Costa Rica, Mexico, and Peru. There's also a lot of mental health issues, for example, high rates of depression and suicide that have been reported, and I know that Raphael spoke about minority stress. High rates of sex work, unprotected anal intercourse, low rates of preventive health care, and that's seen throughout the Caribbean. And also, as Raphael mentioned, illicit use of feminizing hormones and silicone. When we talk about health behaviors, I think, there are a lot of agencies that really want to focus in on the aspects such as substance use and sex work and testing and treating folks with HIV infection. But as you can see, the root of all of this, as Raphael has said, is whether it's transphobia, homophobia, stigma against sex work, or stigma against drug use. That's really where we actually have to focus our efforts. And as far as solutions go, I mean, there is no single solution to this. There are, multiple barriers to care, and we have to think about really a multi-sectoral response. So, and that's going to take a lot. It's going to take, political will, it's going to take legal reform, policy changes, as well as a lot of interventions on the medical front as far as improving access to medical care through medical training of providers and also addressing social discrimination. Thank you.
So hopefully I'll stick to the allotted time. Good evening, everyone. So my focus of my talk was just a basic introduction of the Transgender Health Blueprint, which many organizations have worked on. But before I go there, I just wanted to give a shout out to the National Advisory Board of the Center of Excellence for Transgender Health, many of whom are here in the audience. And the Center of Excellence for Transgender Health includes community perspectives by actively engaging with our National Advisory Board always, wherever we can, and we try to engage them in public health meetings as much as possible. So, there are many of the NAB members here in the audience, and so thank you for being here tonight with us. So, the blueprint for the provision of comprehensive care for trans persons and their communities in Latin America and the Caribbean has been a joint effort. And some of the organizations that have participated in the creation of the drafting of this document, you can see all of these logos up here. And logos are representative of organizations, but not necessarily of the people behind those organizations. And so there are many people who have contributed to the development of this document in progress. And so I just want to give a shout out to those who have contributed but are maybe not in the audience tonight, and some of the people who are here who have, are representing these organizations. So I was asked to speak a little bit about the process for drafting this document. Some of you may be familiar with the fact that PAHO and IPAC previously had published an MSM blueprint in 2009. And that blueprint, actually I believe it was presented in Panama in 2009. And as a result of the publication of that document, there was discussion and agreement made that there was in fact a need for a very separate document for transgender people. And so then in the spring of 2010, I was approached by my colleague, Walter Bochting, who's over here, Walter. So my colleague Walter Bochting came to me with, this request to see if I would be interested in co-authoring with him a draft to present to IPAC and PAHO for this document. And I have to tell you, I had to think about it for a while because I thought, well, this sounds like a huge deal, right? We're talking about a blueprint for provision of care for an entire community on an entire continent, plus the Caribbean. It's, it seemed daunting to me. And Walter reassured me that he would hold my hand every step of the way, and so I said, okay. And so, working with Job and with Joan and with other individuals at IPAC, we started developing an agreement, and we then began to conduct a literature review. And so we tried to identify all the barriers and facilitators to good quality care for transgender people in the region. And what we came up with was actually not a lot, because there had not yet been a lot done. And the other thing is that there was a lot of conflation still of trans issues with MSM and with and visibility of the community. And so there wasn't really a way to yield meaningful information from this literature review that we engaged in, overall. There was very little in the way of journal articles and scientific literature, yet we did engage in an analysis, and there were themes that emerged from the analysis, but there wasn't enough to create the blueprint. And so there was a decision at that time to then conduct key informant interviews at the International AIDS Conference in Vienna, actually in 2010. And I used an instrument that I had, that my team had developed at the Center of Excellence to conduct such interviews. And then I went through a series of key informant interviews in Vienna with people from the region. So, some of the contributors are actually in the audience with you tonight. And so we conducted these key informant interviews and got really rich data that, you know, I thought was very compelling. And so the interviews were taped, transcribed, and then translated and analyzed using standard qualitative analysis methods. And then Walter and I then spent, you know, more months than what we initially thought we were going to be doing, drafting the first draft of the blueprint. Spent spring and summer of 2011 coming up with the draft. So then we turned over the draft to IPAC and PAHO, and then PAHO, I should have actually included Florian in this equation because Florian was an intern then at PAHO who was tasked with taking, you know, the draft that we had started out with and then you know, beefing it up and adding additional elements. And so that occurred, and then in December of 2011, we had a consultation at PAHO headquarters in Washington, D.C., not too far from here, actually. And so we had an in-person consultation of which we had about something like 35 or 40 people were brought in from throughout Latin America and representative of the community that we were trying to reach. And then we have you know, we got a lot of feedback from the participants of that consultation. Granted, the consultation, at that point, we had an English version of the document. And so some of the participants didn't, you know, were not able to fully give feedback. But then in April of 2012, we had a second consultation held here across the hall, where a few of us who worked on the first draft and other key players, including Anita, were tasked with taking some of the recommendations that had been made, integrating them into the draft, and coming up with a second version of the document. And then it was continued work. Florian was a busy little beaver over in, you know, his PAHO headquarters building, and then there was a translation of the document. And so in June of 2012, we were so happy and so proud to take the document to San Salvador, in El Salvador, and we had a multi-day consultation in the region in Central America with the community that we were attempting to reach. And we got a lot of feedback from the community about the pieces that they felt were still missing from the blueprint. And you know, we realized this is a work in progress, right? So there is, you know, I put next, question mark, because, yes. So because of the things that Rafael mentioned, you know, that there are now additional elements that we need to kind of determine, you know, what to integrate and what maybe needs to be condensed. The document, as it stands, is at 168 pages. You know, at some point, I think we're going to have to say, okay, you know, we have to publish, and then, you know, maybe there will be addendums or appendices or, you know, something we'll have to give. But in my opinion, I think that I'm just going to talk on showing you pictures of the consultation. So just a couple of pictures from the consultation that happened in December 2012. So, so I think, in my opinion, I feel like this is a critical need. It's an urgent need. The community is, you know, the community in Latin America is dying, you know, as a result of a lack of action. So we can't wait forever for this document. We have to move on creating a final draft and getting it out to the community so that they can benefit from it. And you know, we need to make that decision to do it. And so I do agree that there is some additional elements that need to be added. But here are the elements of the blueprint as it stands. And they're not in the particular order that the blueprint is currently in. But we have terminology, description of the population. We have a socio-cultural context, stigma, health indicators, knowledge gaps. We have challenges and barriers to care, so socio-cultural and structural health systems, interpersonal factors, and individual, and individual level. And then we have opportunities, so community involvement and empowerment, partnerships, evidence-based or promising approaches, etc. And then we have recommendations for comprehensive care, prevention and support, infrastructure and settings, coordination of care, staff and provider competency, HIV, STI testing, counseling and treatment, mental health, substance use, coping with stigma, discrimination and violence, promotion of resilience, transgender-specific care. And we also have recommendations for working with children and adolescents and aging populations, recommendations for education and training, advocacy and public policy and research, integration of key informant interviews throughout the document to bring the document to life, transgender organizations and networks in the region so that people know about who is doing what, and additional resources that we were able to identify. And then the care components were based on the Center of Excellence for Transgender Health primary care protocols that we developed with the support of our primary care protocol project medical advisory board, which we are very proud of, that 3 of our members of the medical advisory board are trans identified physicians themselves, which I think is a very kind of unique element to a medical advisory board. So that's the blueprint where it stands. It's, as I said, it is a work in progress. I'm hopeful that we can get the additional elements that are needed and that we can get this out and in the hands of providers for the community where it will do the most good and soon. Thank you. Just one last thing that I want to add. I'm sorry. It was just one thing that kind of struck me that I just have to say. So earlier someone said high-risk groups. And I just want to say that at least for trans people, you know, my colleague Marcela Romero taught me this one. And so I'll just say, you know, she likes to say when people say high-risk groups, and you know, I'm going to put Robert on the spot here, but when, so she likes to say, we're not high-risk groups, we are groups at risk.
First of all, I want to talk a little bit about who we are and what do we stand for, ITPC. I, because we are international, we're a worldwide organization primarily centered on the Global South. The T of treatment, because we're dedicated to enabling effective, affordable, quality healthcare for all people living with HIV with a focus on key affected populations. Preparedness, which is a pretty big word, which is supporting HIV treatment and health literacy, decision-making, and comprehensive treatment-focused advocacy for individuals and communities. And we are a coalition because we're a network of people living with HIV, treatment activists, and their supporters. So, what is a community approach to treatment access? Since 2005, ITPC, through this regional network, the Caribbean Treatment Action Group, we have supported more than 70 HIV treatment access projects in the Caribbean region. And what is our focus? Grassroots projects and community-based organizations, both prioritizing on MSM, women, transgender, IDUs, migrants, and out there, sex workers. Why? I think my colleagues here have already explained why we should focus on these particular populations, but I just want to give a little bit about here's why. HIV prevalence in the Caribbean, Young women account for 50% of all people living with HIV in the Caribbean. Prevalence among female sex workers in the Caribbean goes as high as 27% in some countries. Men who have sex with men, prevalence goes as high as 32%. Dominican Republic, 6.1% among MSM, while in Jamaica is 32%, and in Trinidad and Tobago is 20%. And most of these countries have a prevalence rate in the general populations from 1.10, which is Dominican Republic, to 1.60, which is Jamaica. And the IDU prevalence in St. Lucia is 5%, while in Jamaica is 7%, and in Puerto Rico is more than 20%. So, this is the reality. Discriminatory laws plus poor social security equals high-risk behaviors. So, one of the things that has amazed me through this, while working with the ITBC particularly, is that when you talk to people and they say, do you have treatment at the clinic? And they say yes. And then, why are you not accessing it? So ARV availability at the clinic does not equal treatment access. Free medicines does not equal free diagnostics. And free medicines does not equal optimal regimens. Okay? So we may have free medicines in our countries, but that does not mean that the regimens that are being given to the people are the right regimens. Okay? So what do we do? What we think that actually works is that communities know what they need. And one of the things here, I'm going to give you 3 examples of our grantees. First, what we think are the real equations to empowerment and treatment access. This is quite funny, and I would like to note that these equations are equations that particularly work for this particular project. It's not necessarily an equation that will work for everyone, but for them, it was a total success. For example, in Belize, Caribbean Tracks in Action. The problem that they presented was that due to a lack of data disaggregated by gender identity, information is lacking for transgender individuals. In Belize, data does not exist for the transgender population because there are inadequate data fields in the system of the Ministry of Health. And that was something that they presented. The significance of their project was that they wanted to create a profile of transgender needs that will feed into a larger effort of region-wide advocacy plans. So they created a research model in their grant. Focused particularly on focus groups and interviewed. They interviewed 41 participants ranging from 17 to 45 years of age. And the significance, the result was, recommendations were ranging from educating policy officials, support groups for transgender individuals, better data on their realities and real inclusion in the matters that concern their health and security. It was a questionnaire of almost 24 questions, and it was quite amazing because one of the things that one of the women being interviewed said that they instead, since they couldn't get real therapists or hormone therapy, they would resort to get birth control pills, women. So this is the reality of the countries. And this evolved and it worked with UNIBAM, which is the United Belize Advocacy Movement. This actually has a case, a constitutional case right now in Belize to erode the discrimination for MSM and transgender population in Belize. Next, the other equation is transportation and nutrition equals treatment access. I like to call this the Cazadores del Caribe example. Cazadores del Caribe is an organization that is based in Puerto Rico, Dominican Republic, and Haiti. But this particular project is based in the north border of Haiti and Dominican Republic, in the Dajabon area. So the problem here was that most of the people were saying, the clinic was saying, well, the treatment is here, why are people not coming? The thing is that the children and families, living with HIV at the north border of Dominican Republic and Haiti have treatment at the clinics but are not able to access it due to the poor resources and transportation. Most of the times, these families have to choose between paying for the transportation to the clinic or a day's meal. So when it came to decide if I need to pay for the ride to get my ARV or have food for my 6 children, obviously, first of all, my 6 children were to eat. So it was something of common sense. So what they did was that They provided families the basic food basket and transportation fee to access the treatment at the clinic. The project, once a month, baskets and supplements for families, transportation fees, and skills building sessions to address the barriers that inhibit access to the medication. What was the result? After being funded for 2 years, Casa Joven, the Caribe not only attended the necessity of more than 100 children living with HIV and their families in their north border in Haiti and the Dominican Republic, but they also developed a godfather structure in which, instead of being dependent from outsourcing the funding for the children, they went to various churches and people godfathered different children, so they could keep on providing the services, the food baskets, and the health supplements. And the last equation was community education plus committed individuals equals successful interventions. And this one quite amazed me, because this one just got funded this last round cycle. What was the problem in Women Against Rape in Antigua and Barbuda? The sex workers in Antigua and Barbuda who were HIV positive were not accessing services. Why? Particularly because they were migrant and they didn't speak English. So they felt it as a threat to go into the clinic and receive the services. So what they did was that they, the director of the organization, trained 5 Spanish-speaking women on basic English and math. And those 5 Spanish-speaking sex workers learned English. And what they are doing now, they are doing support groups for other sex workers, for other migrant sex workers in Antigua and Barbuda. So the last question is, knowledge plus commitment equals effective advocacy. We need to train the communities and let them know that we're there, and we're there to help. And we need commitment from everywhere. We need to know who we are, where we are, and where do we want to go. And that will only lead to effective advocacy. And last but not least, one of the things that Anita was mentioning was how the service is provided. Most of the time, because of that same I would say scare or fear of providing services to the populations at risk, the services are being given the wrong way. So the thing that we really need to think about is what we really need to treat people right, and we need to do it now. Okay, so thank you.
Carlos, Joanne, and Raphael. We are running way over time. So I think if you don't mind, we'll just dispense with questions right now, so we can have a reception and you can have an opportunity to talk to all of our speakers at the reception. We have still have 4 more people, and we want to make sure that everybody gets a chance and stays on time. I know I'm looking at Raphael. Dr. Ben Young, who is our Chief Medical Officer and Medical Director for IPAC, Vice President of Medical Services, is going to introduce our next 4 speakers. And thank you, the 4 of you. Thank you for a great job.
Welcome, everybody. It gives me great pleasure to be here in my adopted, sometimes telecommuting hometown of Washington, and to introduce the next speakers at this really important symposium on stigma. I actually wanted to just build a little bit on Raphael's one of the slides about showing the prevalence of HIV among trans versus gay versus heterosexuals, and I think that prevalence curve, in my view, is really it's also not just a prevalence curve of HIV, it's actually a prevalence curve of stigma and prejudgment. And I think that this conversation to me is really both opening and frank, and I really value all of your participation here. I don't have the pleasure of knowing all of you, and certainly our very august speakers, but I hope to have an opportunity to meet all of you in our reception. Our next speakers include Ms. Shane Snowden from the LGBT Health and Aging Program of the Human Rights Campaign, the largest LGBT organization in the U.S. She previously founded and led the Center for LGBT Health and Equality at UCSF. We also have Mr. Moises Augusto Rosario, who is a long-time treatment advocate and educator in the field of HIV. He is the Director of Treatment Education, Adherence and Mobilization in the Division of the National Minority AIDS Council. Mr. Francisco Ruiz has been working in HIV/AIDS for over 10 years in the U.S., Latin America, and the Caribbean. Francisco serves as the Senior Manager of the Health Equity Program at the National Alliance of State, Territorial, and AIDS Directors, where he provides guidance on how to direct and address disproportionate impact of HIV among the most impacted communities, particularly Latinos. And lastly, but not least, Dr. Chloe Schwenke, who serves as a senior level political appointee of the Obama administration in USAID as senior advisor on LGBT policy. Hope I got everybody. All right.
Thank you so much. It is such an honor and a pleasure to be here with you all. Let me, do you have various AV needs to, which one is it? All right, I feel fully equipped. I'll really be an idiot if I can't do this. I'm up here to talk about an intervention that has been designed by HRC, with the lovely building all around us, to address one particular setting in which stigma plays out very, very heartbreakingly. And this is a US-based intervention. It may or may not have gifts in other settings, but we wanted to share it with you. And this particular intervention, we finally know it as the HEI, and that stands for the LGBT Healthcare Equality Index. That is a survey, an annual survey of hospitals and healthcare facilities in the US all over the country. And when this survey was created 5 years ago, there was not very much information, not that there's a lot now, about what goes on for trans people, HIV-positive people, and HIV-vulnerable people in hospitals. But we didn't have a lot of gold standard data, but we had a lot of stories, and they broke our hearts. So we began to think about, well, at least in US hospitals, how can we get at how this stigma plays out? So we do now, in the year 2012, have a little bit more data. I think these data are not going to come as any surprise to you all, but just to quickly review what is going on around stigma in hospitals, let's take a look at the survey that Lambda Legal, the gay ACLU, did in 2010. They did a report of 5,000 LGBT people, a large cohort of them HIV positive, and said, what is going on for you in healthcare? What is going on for you, and what are you scared of? Because as the other panelists have said, there's a lot of fear of even going into healthcare settings, and you can see what their data was right there. These are the numbers for people who actually believed in the year 2010 in the US that they would be refused medical service. The left-hand bar, the navy blue one, almost 10% of lesbian, gay, bi people, not HIV positive, believe they'd be refused medical service. Take a look at the bar on the right, the gray bar. Those are LGBT people living with HIV. 1 out of 5 actually think they're going to be downright refused medical service. And then you look at the other number, slightly over half of the trans people surveyed actually thought they'd be turned away. They were also asked, have you been denied medical service? Almost exactly the same numbers. The fear is there and the reality too. Let's take a look at another question they asked. They uncovered a tremendous amount of concern about people being treated differently, and by treated differently, nobody meant treated better. Surprise, surprise. Surprise, surprise. So here's the data from Lambda Legal. You can see almost a quarter of the lesbian, gay, bi people not HIV positive believe they'll be treated differently. Again, the year 2010 in the US, this is a rather well-educated cohort. You have over a third of the people living with HIV sure they're going to be treated differently, and look at that. No surprise, everyone's been saying, but this is the US now. 3/4 of the trans people think they're going to be treated differently. So you know, Lambda Legal asked, what do you mean by different treatment? Here we go. Look at that, almost 2/3 When did the epidemic begin? The early 80s. Almost 2/3 of HIV positive patients, almost 3/4 of the trans patients had had at least one, and often more than one, of those 4 kinds of healthcare experiences that just show stigma and how it plays out in the healthcare system. I would say these are the 4 worst things that can happen to you, short of medical malpractice, where they, replace the wrong knee or take out the wrong organ. So number 1, of course, related to stigma, being blamed for your health condition in the first place. Sends you right out of healthcare. Number 2, stigma at its most raw. People refusing to touch trans people, refusing to touch HIV positive people, putting on extra gloves, moving away and wanting to get out as soon as they can in US hospitals. And then finally, harsh language. HIV positive people and trans people, not fully human, not people you have to address with respect, not like other people. And then physical roughness. You don't matter. I don't have to treat you with care. And I know I don't need to tell this audience, you got from the other panels, these numbers were much higher if the respondents were people of color and or had low incomes. All right, so the HEI, how does it deal with these things? It's an annual survey of hospitals. It says to them every year, we want you to evaluate yourselves according to consensus criteria for at least foundationally decent care that is not related to stigma. Now, since we started doing this survey, some of the anti-stigma criteria that we ask of hospitals are now required by regulators. In the year 2011, and you're going to see these criteria are not very high bars, but it was not until the year 2011 that the criteria in the HEI, some of them, were required by hospital regulators. And the way the HEI works is, it's a little like kindergarten or first grade, where you want to encourage everybody. All the facilities that take the survey are recognized in a report that's out there on the table and that you can get from us. They're all recognized, they're all honored, all 407 of them, for caring, for at least trying to engage with stigma. But we will give leader status to the ones that really, really try to engage with what we call the core 4 criteria, the 4 core criteria for fighting stigma and giving decent care. And we have a little over half of the hospitals are going for the gold, the leader status. The way, it would be wonderful if we were in a world where hospitals just wanted to meet these criteria for anti-stigmatizing behavior because it's the right thing to do. But we also give them an incentive. We say we're going to declare you to be a leader in healthcare equality. We're going to give you this logo that you can, so you can say to stigmatized communities, we see you, we care, come on in. And the way I describe it to them, this is their good housekeeping seal of approval. You'll see these are pretty basic criteria, however. Here's the first of the core 4 things we ask from them to stop at least fundamental stigmatizing behavior. And this is a requirement now from their accrediting agency, which is the Joint Commission. And it's very basic and very important. In their non-discrimination policy for patients, include trans people, include lesbian, gay, bisexual people. Now, of the hospitals, almost all of them protect sexual orientation. These are our star hospitals, only 3/4 of them protect around trans status. Our work cut out for us in the good US hospitals. And what we ask them is, for goodness sake, if you do it in your policy, make it visible. Don't make it your little secret. Get it out to people. And don't just get it out to patients. Make sure your employees know. They're on notice. You do stigmatizing things, you're in violation. We also ask of them, you set up a clear complaint mechanism so that people who still get stigmatizing treatment know where to go and what to do. And this is a very similar thing we ask them in the non-discrimination policy for employees. Also to include sexual orientation and gender identity protection. Same story though. 90% of them protect around sexual orientation. Lesbian, gay, bi status, only 3/4 of them protect on the basis of gender identity. Again, I would say these are the hospitals that are trying hardest. And again, you want it to be visible. You want the employees and their managers to know about it. Because we know realistically it is LGBT employees who kind of keep an eye out for the vulnerable, who say, don't do that, don't do that. And then again, you want it to be clear how someone can report stigmatizing behavior. We also ask that they have, and this is now required by their accreditor and by the feds, for goodness sake, have an equal visitation policy, so basic. But again, not a common thing, even though it's a federal requirement. Inform your patients that you have equal visitation, regardless of sexual orientation or gender identity. Don't create a higher bar for LGBT visitors. So in hospitals now, transgender visitors, they don't want a transgender person back visiting their loved one. Might disturb the other staff and patients, so they'll create a higher bar. Get paperwork. Don't misuse the exception for medical necessity to keep a man with HIV from visiting his partner with HIV in the hospital. Don't have staff stigmatizing the men because one takes the other's hand and engages in what we used to call a public display of affection in high school. Finally, all the policies in the world, the great words of Duke Ellington, the health educator, all the policies in the world don't mean a thing without that training. As all of my co-panelists have said, we require them not only to have those 3 policies, but we require them to take training, to have their senior administrators take the training. We believe that stigma preventing efforts start at the top. We require them to be from certain areas. We worried, frankly, about how many of them would comply with this. They loved the training. We've trained 1,200 senior administrators. They're jumping all over it. Finally. So there is good news. We also asked about a variety of other things. I'm getting the time signal here, and I'm determined to come in under the wire, but I can tell you really quickly, we call for even more support for employees than just not discriminating against them. Support your LGBT employees. They're your watchdogs. Allow trans patients to self-identify if they want to. Let's eliminate confusion at admitting if we can. Check your medical services. What are you doing for trans patients? Are you acknowledging an older generation of MSM with HIV who are coming in for elective services in their 70s and 80s, are attached to their HIV meds? Are you ready for them? It wasn't even thought they'd live long enough to have those surgeries. How about your inpatient policies? Are you rooming trans people in the gender that they say that they are? Good question for hospitals today. Are you meeting with the community, the stigmatized communities, and hearing what happens to them and other ways you can help? And then we raise the bar more every year. If you want to know more, amazingly, we have a website. There it is. We unveiled the HEI this year, just a month ago, with Health and Human Services Secretary Sebelius over at Howard University, just minutes away. So you can learn more about the HEI. You can take a copy out there. We hope that this will be replicable in other settings, in other countries, but at the very least, we really invite you to help us spread the word here in this country. We find it to be, in its own way in hospitals, a powerful anti-stigma mechanism. That's all for me.
Hello everybody, and my name is Moises Agosto, and I was asked to be here in this panel and talk about the issue of the stigma, particularly among the MSM community and within the MSM community, the experience of the HIV positive people. But for once, I kind of would like to feel that I can talk about stigma with this kind of like very formal and evil thing that we look at from the outside and that we never look from the inside within ourselves. So I wanted to first kind of ask you, how many of you feel that you have never, that you have been stigmatized by someone, or that you have stigmatized somebody or something, for whatever reason? Raise your hand. So the point I want to make with that is that, and I'm going to pass this, always me. I'm going to pass this as kind of the topics that I wanted to discuss, but when you look at the slides, I don't want you, this is kind of like the official meanings of the word of stigma or the experience, but I want you to think you individually, more in a personal and intimate way, and looking at the way you interact with yourself and you work with the stigma that you have in you, or you interact when you interact with other people. I think that's an important conversation that we rarely get to have. Meaning of a stigma, as we know, comes from the Greek and refers when people get marked by something, even if it's physical, through fire, knife, And it's also to pinpoint an individual because of their moral status, because they have problems with the way they're different, and their sign they get in their bodies or the signing or the group as the one they belong, they get, that is the advertise of this is a person to be stigmatized against. So here, I mean, it's discrimination and stigma, it goes close, because discrimination is something that go out of the stigma that are within a person, even within us, or within a person that is interacting with us. So discriminations manifest in many ways, in many actions. People get violence, as you can see in this picture, or people get like uncomfortable with something that is different, like seeing two Muslim men kissing. So within our community of MSM, one of the things that is kind of interesting and funny is how many times or how many ways we can stigmatize ourselves. How we play with the stigma on ourselves. Like we have, for example, I was listing ways in which we can create those physical things or lifestyles in which we can stigmatize them on ourselves. Like let's say we have the bear community, we have the leather community, we have different kind of like the cowboys, or we have the butch, the lipstick lesbian. We have, you know, even on ourselves, we tend to separate groups. And instead of kind of like, sometimes we make an effort to get alone on ourselves, sometimes in a more intimate way, we get, you know, we keep it as a secret, but, you know, I'm not really into this. I'm not really into Puerto Ricans, let's say. You know, or oh, I'm into Puerto Ricans, or you know what I mean? Like I think about the ways in which I've been stigmatized because I'm Puerto Rican. I've been stigmatized because I'm gay. I'm being stigmatized because I'm HIV positive. And the fun way is how it manifests sometimes. I remember once when I moved to the States for the first time, people will talk to me and will say, a guy was trying to pick me up in a party, and he said, "Where in France you're from?" And I'm like, no, I'm from Puerto Rico, but you have an accent. So I go like, yeah, because I speak Spanish. So you're Puerto Rican? And yeah, okay, I'm gonna get a drink. He left and never came back, right? But then that also was in a positive way. You can get stigmatized, and people say, "You're Puerto Rican." Oh, it's just an example. Another way was this guy I met in a bar. I had this rule that when I was going to go to a bar, if I wanted to have fun or met someone, like by 2 o'clock in the morning, I will disclose my status. So I'm fair, and I give you time to go ahead and, you know, be with someone you're comfortable with. My choice is to be open about everything. It's more comfortable for me. Doesn't mean that I don't feel the effect of it, but it's easier. So one guy came, you know, and I disclosed I'm HIV positive, and he said, "Oh, that's okay, I'm fine with it." And then we were joking about things, and I said, "Oh, another thing, I snore." And this guy just opened his eyes like, "What? You snore? Oh no, I can't go home." So you see the games that we play. But the point even upon ourselves, we can the dynamics that if I don't go through the whole slide, what I want us to think is how we relate to stigma, how we use the stigma within ourselves and with others. So here, the next one, very quickly, I just try to, like, you know, this kind of official, this kind of common sense. We know the things that bring us to the stigma, the biases, the racism, the prejudice, the stereotype, the discrimination, you know, and this happens outside in the world. This happens every day. We could be a stigma walking around, but also it happens within our community and how we treat each other and how we respect each other. And I think that's kind of the point I want you to go home with, more than anything, that you understand that comes from a Greek origin, the word stigma. We are all grown up, so we understand what discrimination and stereotype how they play a role in the development of the stigma. Okay, so very quickly, it becomes like you see very vicious cycles happening. And I'm going to give an example, and I try to tailor it to us. Stigma and discrimination goes around and around in vicious cycles. And stigma allows us, or encourage that we could be discriminatory against somebody. And there is a gay person in a clinic, and said, or a straight person that they said that doesn't discriminate. I said, gay men are very loud and promiscuous, whatever that means. And then in the cycle, you see that then these attitudes are often reflected in discriminatory behavior. You know, people discriminate, and people say they get so many STDs and contagious infections. Tell him that the doctor it's booked for 6 months. You know, and that's kind of a day-to-day way in which we see that manifest. And then at the end, those out of stigma, you know, this discrimination, draw the attention to increase that stigma even more. When another person in the office say nobody wants to deal with him, you know, I don't want to catch anything, and they bring it home again. So, in terms of people living with HIV, how stigma became such a big issue within ourselves or in our community is like, as you remember, in the beginning of the epidemic, this disease started to be noticed among a group of gay men in New York City, in Los Angeles, and other big urban cities. And in the early, you know, the media reports refers to AIDS as the gay disease. So immediately we got that last name, you know, gay, AIDS, that stigmatizes us. They get cancer, they get plague, and HIV was commonly referred as green. So that has evolved, but that is the origin of which, you know, you could see that immediately as it came out, it became a reason to stigmatize us men that have sex with men, even another layer of the stigma. So the targets of a stigma, you know them very well. There is a primary, the individual. There is the people that are around the individual. Like for example, I had a boyfriend who was negative. And when we broke up, he started to date another person. And a friend of mine went to the other person and said, be careful with this guy because he dated Moises. And you know he's positive. You know, it's you and the people that are around you. So how it manifests, people get fired of their job, they get thrown out of their houses, etc. And then this is something that, you know, we understand the attitudes in the society, but also the attitudes within the individuals, healthcare providers, counseling services, and in our daily life, our families and relationships. This is something I want to really highlight a little bit because people don't talk or are afraid to talk about it, and it's the self-stigma within ourselves, and even people living with HIV. That it may be caused by the homophobia, the shame of being a person that is infected, the experience that I internalize, you know, of the negative responses that I receive. So it's very important that we think about that it's not the stigma from the outside, but we can kind of like get self-stigma in ourselves, and this leads to us like withdrawn from society. And in this slide, I found it interesting how it makes the point that it's internalized. But within HIV, I don't think that it's just only a matter of internal feelings. I think that stigma is also related to diseases that are associated with disfigurement, with death, like cholera. And in HIV also is very, very like fertile ground for this kind of issue about image, about we take treatments that may stigmatize us. Once, and very quickly, I was in Peru, and I saw all these people that had a lot of like buffalo horns. And I see this guy with the long hair, and we started to talk about it because I'm terrified about it. And what this guy had long hair, he said, look, he had this huge buffalo hump, but his way to deal with it was leaving his hair long. It sounds silly, but it really touched me when he showed me that. Okay, so think about that, look at that picture, because I've been among people that they can pinpoint, I'm going to pass those, they sit down and pinpoint, look, that one have it. Look at them, look at his face, look at his legs, look at this. So, you know, that we think about about the image. And also doctors that refuse to help you to improve your image if the treatment that you're getting is not helping you. Like I have found that experience also with some doctors that they don't think that it's important if I want to get my cheeks, you know, feel, or if I want to get growth hormone because I feel my belly is so big now, or I have nothing here. So anyway, so in conclusion, doesn't even matter. It matters, but what I mean is that we need to look at diverse and very diverse ways to deal with the stigma. And this is not just one solution that's going to fit all the issues that come up with the stigma. We need to own that we also are part of that stigma, and that we stigmatize sometimes even without even realizing that we're doing it. So in terms of us dealing with it and working with the stigma, that we all try to transcend that kind of like separating us and them, even within our own community, our HIV community. And this is my favorite slide at the end of the presentation, is sometimes you go to the websites and this just speaks for itself. You know, you find in a profile, clean UD2. And I won't explain it. I'm sure that many of you, who doesn't get it? Okay, you all get it. Dirty is not for laundry. Dirty is for laundry. Not your HIV status. So with that, I leave you, and thank you very much for your attention.
Okay, thank you very much. You made it to the long list. I'm the last. Hope I can keep you away. I'm talking from USAID, of course, about health, but also about development. We are the U.S. Agency for International Development. And so we're tasked to look at not just the health issues which stand in the way of development, and which in many cases define development, but we're also tasked to think about the whole picture. We've got to bring this whole thing together. The barriers, well, we've been hearing about them all night. Stigma and discrimination. And they're formidable barriers. They're not easy at all. Yes. Stigma doesn't come out of anywhere. One of our biggest challenges is just simply to break the pervasive silence in developing countries that in many places where stigma is simply allowed to happen. It's not, you know, we understand why. It takes a lot to put yourself out there, especially for straight allies, to actually stand up and say, stop. But that's got to happen. It's really important. And of course, ignorance. There's just so much misinformation, lack of information, pervasive ignorance, and really hard to get There's also something that is as old as humanity, and that is we make people the other. And when you keep being told you're the other, you sometimes bring that into yourself as well. And it's never a good place to be. For transgender people, and I'm speaking from experience, it's a particularly challenging place to be. Homo sapiens have been around about 50,000 years, and you can be sure that the first time a baby was born that was identifiably Homo sapiens, they decided right away whether it was male or female. And a whole set of expectations began at that point. So your sex assignment from the very beginning sets up a standard of otherness. There's going to be another, for sure. And if you happen to know that that assignment is wrong, you've got the whole of human history going against you. That's pretty daunting for most of us. Okay. This Melissa Miner is doing some really important work in Uganda right now. She's a doctoral student who's mentoring a little bit. But what does this really mean? You hear from trans people themselves. I'm not going to read that quote, I'll just let you read it. These are a couple of Ugandan people that, she's got an amazing collection of just experiences and testimonies, I call them, narratives by people who are just talking about what it means. The most important thing to me is the bottom line. Enough stigmatization and you don't go back for care. And in Africa, I do most of my work in Africa and the Caribbean, and the level of stigmatization is awesome. That's not a word I use very well. Okay, the next please. And this one is slightly longer. Again, the situation of suicide, well, here it is. It's a burden, and it's a burden that affects us as mental health providers as well as physical health providers. We can't think about these in disaggregated little tiny packages. We have to bring the whole thing together. And that's how human beings are. If we don't bring the whole of a human being together, we don't achieve development, we don't achieve health. So it's an important thing. The first place we can help as USAID is to really break through the ignorance, to get some really solid information out. And I think, the kinds of sharings tonight, the data that we've been seeing, getting those out, but finding ways to get them to people, working with media, working with advocates, working with others who simply don't know. So one of the things we do a lot of work in is in those sectors, particularly with media. We certainly understand that there's no simple solution, there's no one-off solution. Human beings are complex. We have to find situations and interventions that really work with the populations we're working with, and that's tough. You've been hearing all night long how the T has been dropped. We don't collect data. Nobody collects data on transgender people. We're only just beginning right now. USAID, we're committed to making that happen in our future work. But it's tough. The data simply isn't there. So it's hard to structure, to design interventions to meet particularly that population. We're a little bit flying in the dark there. We have our own experience, but we don't have good data yet. Okay. I mean, it's actually more challenging than just the data. You've got to remember that some people who are transgender don't use those words. That's not a word in their culture. So even finding the tools to get through the data is going to be really challenging. We are working on that. We're working on that right now to create new protocols, new ways of getting past the difficulties, of getting the data that we need to demonstrate progress, to find interventions that are really going to be effective. And that's something that's really important. One of my top priorities for sure. Okay, next please. And one of the ways to do that, of course, is not just to go out and do anonymous surveys, as important as that is. We have to get to people who affect people's attitudes. If we can't begin a dialogue, an open, healthy, wholesome, human dialogue with people, to really engage them, we're not going to do it. We're just not going to get there. Attitudes are going to be the wall of stigma. We have to get over that wall. And we as USAID can't do that. We can facilitate that, and we do. But leadership in the countries we work in, that's the challenge. That's who we have to get to. And it's at all levels, government, civil society, everywhere. That's who our targets are. Okay. Our challenges are huge because we work across many different sectors. We bring many different skills. We're the largest bilateral donor. We feel the weight of that responsibility because with that coverage, with the resources we have, we're challenged. We know we can make an impact. We need to make sure we use those resources well. It's a moral burden that we take on and we accept. And we do it by a whole number of ways. Our approach right now to LGBT health and human rights is that. It's both. It's not just a health challenge. It's a human rights challenge. We're there. We're there in both of those areas. We're there with very strong and unequivocal messages about the importance of human dignity and human rights, and that's a language we're not afraid of. We'll have that conversation. We'll also have a very rigorous conversation about health interventions. We'll do the work, we'll do it well. And of course, advocacy is everything. We have to make some changes. One of the biggest challenges for us, and I've just mentioned this before, is getting to the data that we need. And we're going to be doing that, but right now, my population's been left out. Other populations have been treated in ways that are not comparative, and that's a challenge because the categories are not always the same, and the language is not always the same. So we're working through that as well. I'm just going to show you a few of the projects. We've got multiple projects that we're working on. Just next, please. We make toolkits that we use all over the world. Some of these are really, really solid. They've been really very well, regarded. We're doing a lot of work on issues of violence and how to work with violence, how to control violence. We work with groups, with transgender groups. This is the Purple Sky Network. We've been supporting this in particular in Thailand and other places, the Sisters Projects and others, to not just talk about health, but talk about mental health, talk about wholeness, fulfillment, community. One of our most important projects in Jamaica just last year did an amazing survey to look at where stigma is coming from. What are the shame and blame issues that are coming up? What do those look like? What are people saying? And that's data that's critical for us. So, health interventions certainly. But we have a lot of different places. You know what I hear when I talk to LGBT people, especially trans people? The very first thing they consistently say is we need someplace safe. What can you do to help us get that? And I've been hearing that, and I've been sharing that with my colleagues, and we are aware of that. Training, of course, is important. The whole decriminalization piece of work, critical, and something we're very much engaged in right now. Public services across the spectrum, not just health, that understand LGBT people, that are aware of what our needs are, that are open to that and trained to be that way. And getting LGBT people away from being the victims, letting them be engaged, letting them be right there. This is their development, their health, their situation, their advocacy, their challenges. We know that. We know that from a lot of experience. So where do we go from here? Okay, next please. Doesn't matter. We go from here primarily in building capacity. We have to work with our NGOs around the world to ensure that they are leading the charge. That's our job. We facilitate development. We're going to be working with them to do better health and research work, getting the research done. We're going to be working across sectors in ways that are coordinated and make sense. Most of all, we're going to use what we've learned in 50 years of doing this kind of work. Maybe not specifically with LGBT, but we do know how to be effective. We do know how to build capacity. We do know how to facilitate advocacy. We do it and we do it well. That's what we're doing for you. And that's what I want to share tonight because I am as proud as punch to be a part of it. Thank you so much.
Thank you all speakers for a really riveting and enlightening set of discussions. I get to take moderator prerogative to say a few words. Again, thank you all for participating and coming so far to be here. I also want to thank the Human Rights Campaign for the lovely building and facilities, to the International Treatment Preparedness Coalition and PAVO, our partners, as well as our colleagues and friends, Andrea and Angela from the Human Rights Campaign and from IAPAC, who arranged all of this. But mostly to thank all of you for taking time out of an incredibly busy schedule, and hopefully to have an interesting and provocative dialogue in our reception where you can have food and drink, and I hope that we all have a chance to meet each other. And thanks all again for coming.